All right. So now let's go. And so just let y'all know, this chapter, you will see chapter 10 on here. You'll see chapter 9 on another one. It's the same. So don't worry about that. You're good to go. Um, so this is a really big chapter. I have divided it in half. You'll get half of it tonight and then half of it Tuesday. So you won't have I'll have to create a different attendance code so it'll be for 2 nights. But just to let y'all know, so it is really big and it does go into depth, and that's the reason why I wanted to divide this up so not everybody was worried. It's that's the best I can say is it's rather large, so that's why it's going to be divided up into 2 nights. So patient assessment, we're going to get going here. We'll kind of make sure everything's situated, good to go. So we know this is our national EMS standard competencies. If some of y'all have looked at the slideshows, I've changed it. I've added some stuff into that. So that's why you may see some differences versus y'all's or what's on was on the site. Starting here, scene safety. This is what we're going to talk about throughout it'll go overall and then we'll dive into this individually. Scene safety, scene management involving the environment of the patient, on patient care, addressing hazards, violence, a need for additional and specialized resources, standard precautions, multiple patient situations. We'll go into primary assessment. We'll talk about your local level of consciousnesses, your ABCs, what that stands for, identifying life threats, assessment of vital functions, initial general impressions. We won't talk about all this tonight, but I'm going to cover it in the beginning. So when we pick back up Tuesday night, we don't have to worry about it. We're going to talk about beginning interventions, need for preserve of life, and integration of treatment procedures needed to preserve life. Go over history taken. Why is it important to talk about their history? We want to know in depth, determining their chief complaint. Just because families like, hey, look, I just called y'all because he's always like this. But Fred says, my toe hurts. That's the reason I want you to take me to the hospital. That's his complaint, period. Chief complaint, my toe hurts. So we're going to talk about that in depth. Mechanism of injury versus nature of illness. Those are big. Associated signs and symptoms, investigation of the chief complaint, past medical history, and pertinent negatives. All those will build you, each individual, like you'll learn how to do a general impression, a general scene size up. You'll learn how to do a patient assessment, but like the ones that I do versus what Rob does versus like y'all heard me talk about Justin the other night, and even Brandon, our own site instructor. We all do them differently, but the overall outcome is the same. We ask questions in different orders. Some of us may ask more specific questions because it's just something we want to know or it's important to us. Secondary assessment. Just because we do our primary assessment, we have to go into a secondary and or detailed, depends on which book you actually read from. So the secondary assessment is you performing a rapid full body scan. You're going to do a focused assessment of pain. Now, this, when I say focused, I know this is not in tonight, but we're going to talk about in depth. Why does your right arm hurt? You're going to put your hands on that arm. You're going to inspect it. You're going to look for all these different things. I don't want to dive into it tonight to confuse you, but we're going to do each individual section of the body is going to be assessed differently. Assessment of vital signs. Why is it important to know beginning assessment versus the trending assessment while you've had them? Techniques of physical examination, respiratory system, presence of breath sounds. It is very important to have presence of breath sounds, just to let y'all know that. Later on, we'll talk about the cardiovascular, neurologic, musculoskeletal systems, and all anatomic regions. All right, since that was a mouthful, cool. Look, we're still into it. Talk about using non-invasive blood pressures. We'll talk about pulse oximetries, what in the importance of that is, why we want to have those. We need to have those and the different tools that we can use to make it just as important. Hey Ash, I saw you in the call. If you want to really want to aggravate your daddy, tell him he's late. And Chris has got this, so tell him don't worry about it. Give him a hard time. So these different tools that we have and the accessibilities of these tools is what's important. Um, Using them in the right time and the right situations gives you a kind of like a baseline and a database to build from when you're writing your reports. We're going to know how and when to assess patients and when to reassess them. When we need to perform a reassessment of all patient situations, we'll talk some into that. We'll go over these next few slides, just the three of them. So patient assessment's important. EMTs master the patient assessment process. If you guys remember, I told y'all to print off your NREMT checkup sheets. Now's the time. This is when you start memorizing them as we go over these in different sections, because you will need to master these masters of um, uh, situations and times and places is when it starts to get important. And as we're talking about them, hey, Rob, it's all right. We got this, bro. We early. We got this. Mm-hmm. And so you understand these patient assessment sheets and why we emphasize you so much. And if you have it, it's pretty good to bring it out so you understand the differences of why we break this down in sections on that patient assessment for the National Registry. It's a lot too, but it's very important. All right, so introductions. I talked about that tonight. I'm gonna tell you we're gonna go over scene size up, primary assessment, history taken, secondary assessment, reassessment. Yes, Rob's going to be keying in at different times and points tonight, so him and I may be fighting for time and space to talk. Rarely does one sign or symptom show you the patient's status or underlying problem. You need to know what the symptoms and signs are. Symptom is a subjective condition that the patient feels and tells you about. Sign is an objective condition. Basically, what I want to know is, tell me how you feel. What besides that tree sticking you through your stomach? Tell me how you feel. What's going on? Can you remember what happened? Build a that build a background of, just because you were like, oh, dude's calling me because he got a limp through his belly. Well, I need to know what kind of symptoms he's progressing with. All right. So now comes the fun part. So this is where we're going to start our scene size up. You're, I'm probably going to get this out of order because I'm going to talk about it and then I'm going to look at the slide and be like, oh, they're already talking about that because I already addressed it. So my bad. All right. So your scene size up is the turns on how you do your operation, how you perceive things, how you look at the scene. You need to listen to what your dispatch tells you. If your dispatch is, you can tell in your dispatchers. I don't know if some of you have been into this before or listening to different things, but the sound of your dispatchers determines a lot. If they're startled or they sound like things are emergent, then you potentially might be. And so it depends on how things are, how you build your basis. So no matter what, any kind of scene, you always have to have situational awareness. If you lose track, you don't pay attention to what's going on, and you get blindsided. You put your blinders on. Didn't I need to talk? Sorry, I'm talking behind you. All right, so you put your blinders on, you can be hurt just as much as the patient and or worse. So we need you to build a scene size up and always figure out what's going on. So understanding situations and conditions prior to responding, if you know the area, be like, look, I know that area always floods. We need to be careful because, there's no sides of the road. Like it's literally like pavement drop off. Dispatchers basic information, what they tell you and how they tell you, they may give you specific details. And I can tell you, no matter what we always say, the dispatchers don't ever give you enough information, but you have to recall they're only given so much. They don't have a drone that's always flying and they can fly over the area. They can only relay what they are provided with. So they didn't tell you something, they just didn't know it, even though we're going to blame them. I have a different term for them, but I'm going to leave it pretty nice. So I won't tell you what I call dispatchers. It's not that ugly. But observations of the scene, hey, I realize I got a down power line. I have to be careful for that. I may not be able to get air operations in here because of the power line. You may respond to the area due to a storm or some flooding that's taken on. When we talk about precautions for unstable surfaces and slopes, remember you're also going to be parking your units, your ambulance, your fire truck. Depends on which service you folks are going to be working for, depends on what you have. You may have a type 1, type 2 ambulance. It all depends. You could even be fancy and drive these Mercedes Sprinters. But you got to be very careful about where you park them, how you park them, the ice, the water, and if things are all, if water is flooding in the area, just be precautious. And then where you park your vehicle, how you park, is it safe? Have you blocked the scene? Is fire there? You think about all these different things that you're trying to build a scene size up as you're responding as once you get there. Always remember, and I added this in there later on, if you know that batch or fire or police, if you work in the same station as the fire does, you are potentially going to be responding to a hazmat scene. Always, always, always park uphill, upwind. Chemicals can't flow uphill, and the chemical can't be blown upwind because wind's pushing it away. So just be always careful and mindful of that. If you have to divert because you know the wind is blowing in a certain direction, that's fine. And just tell dispatch, be like, hey, I'm going to have to divert because we know that the windsock at the hospital when we passed it. Something. I say this is the next bullet is maintain an escape route. I do that on a daily basis. Is when I sit around and eat. I want to know what's around me. I build my scene size up. I know where my exits are. I know how to get out of there. So think about that specifically if you're on a scene. If the scene turns violent, and when I say hazard at the bottom, if the scene turns to where you're just not comfortable, you and your partner need to have a terminology, a word, a phrase, or something that everybody knows. Oh, I'm sorry. I started my yawning early. That they know that it's time to go. Like I need to go now. That it's ready. Like we gotta go. Like, hey, did you get the blue bag off the stretcher? That may be the sign to your partner, being like, oh no, hey, can you help me go get it real quick? And you just leave. It's time to go. So that's what we're talking about. This is the basis of building a scene size up. I want to know what I'm going into. Now, you're not going to always know what you go into, but you start building ideas. You always want to ensure that the